Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us. Good morning, June 9th. Thanks for joining us for the Wild Health COVID update. I'm not going to go over the big numbers today because they're getting really big and they don't really make sense in that context. Just to look at the world numbers and the U.S. numbers, you really can't tell anything from the fact that, hey, we've got about 2 million cases in the U.S. and about 112,000 deaths. So instead, I wanted to just talk about what's happening currently. What are the trends now that we're opening back up and there's a lot going on? And I woke up this morning to a couple news stories that popped up. One was in Arizona. There had been a big jump in cases, also in Texas, and I saw something about my home state in Kentucky. So it's hard to make anything from the news and the headlines. So I actually went to a site that looks at actual cases to look at these places, because if you look at the U.S. as a whole, in the last 3 weeks, we're just kind of going up and down, not changing a whole lot. And it's ranging anywhere between 16,000 and 25,000 new cases per day in the last few weeks. But an interesting thing I noticed is that the third biggest day was yesterday that we've had. You don't see a great downward trend. And in fact, in these states that I just mentioned, you actually see us going the wrong way. And we're not talking about that very much right now because there's so many other things going on. But the numbers, when I looked them up today, were somewhat worrisome. In Arizona, which is the first news article that I saw, on May 26th, when I look back, they had 222 new cases. And on June 6th, a couple days ago, the last day that I had data for when I looked at this, they had 1,500 new cases. I then went to the Texas example because that seems pretty extreme. Maybe something weird is going on just in Arizona. And in Texas, they had 589 cases on May 26th and 1,940 on June 6th, 2 weeks later. And in Kentucky, my state, we had 117 on May 26th and 319 on June 6th. So we've talked about this before in the context of when you look at the United States as a whole and you see dropping numbers, a big part of it is because of the initial spikes, like in New York, New Jersey, those places. They're coming down, but other places are not. And it gives the rest of us a false sense of security, I think. So in New York, for example, during that time period, there was a decrease. It was from 1,100 to 781. And so then I started thinking, okay, what's going on here? Is it just the fact that we're doing more testing because more testing is coming online? We, in fact, have done a lot of testing in that time period. So I then went to the deaths, and that was not really any more comforting, Mike. In Arizona, from that time period, May 26th, they had one new death, and on June 6th, 2 weeks later, they had 30. So from 1 to 30. Texas went from 9 to 31. Kentucky also went up, and New York went down from 79 to 47. So there are some troubling trends that we're seeing, and we just want to call that out as we're talking about, because I think those kind of trends and looking at a micro level are sometimes a little more insightful than on the macro level, what's going on in the world or the United States. We can lose sometimes the trees for the forest in these cases.
If you look at the U.S. curve, it's sort of plateaued off, and it's almost like sort of like a slightly decelerating plateau off. And, you know, two problems with that are, like you were mentioning, there's all these little microclimates of disease spread, basically, like Arizona and Texas, while New York gets better. But there's also the reality that things are going to be delayed. It's not going to be immediate when you open back up that you're going to see a new spike. It's going to take, days, weeks. And that's where we're at. We're basically at that time frame now where we've been open for a few weeks now, depending on where you're talking about. And, we expect to see a little bump. And the question is, how big does this bump get in some of these states? I heard that Arizona is actually filling up its hospital beds and are looking at reaching capacity, which is obviously concerning. I think it just depends on what we see the rest of the country in terms of how quickly this continues to move, whether we're going to get that slow burn that we talked about a few podcasts ago, or if we're going to get these little mini spikes on throughout the rest of the year.
And these are worrisome states to me too, because they're states, Arizona, Texas, they're not super dense states, and we would expect summer, hot months, people are outside, not inside in these areas. I would not expect to see what we're seeing. So I don't know. It almost, when you start talking about numbers and what's going on, I almost feel like you're making political statements, and we don't want to do that. We want to stay away from that, and that's why I just want to talk about these numbers because I'm still concerned about it, and we're going to keep watching the numbers, and we'll keep reporting the numbers, but we'll try to do it in a way that actually is more meaningful for people. If you want to look at this yourself, there's actually, if you just Google United States COVID cases by state, there's a really nice little graphic that comes up, and you can search by cases and deaths and individual states and the entire country. So if you want to look in your area, you can take a look and see what's going on. But I'm not hearing, it's interesting, going from 222 to 1,500 in Arizona, like 7 times as many, Texas tripling, Kentucky tripling. I haven't heard anyone talking about going backwards. All I've heard is going from phase 1 to phase 2 to continuing to progress. So there's a little bit of a disconnect, it feels like. But, I mean, we got policymakers making policy. We'll just keep reporting the numbers and keep saying what they are. You want to talk about some research, Mike?
Yeah, I've got quite a bit to talk about today. Start off with, this isn't really a research article. This is more of a study that's ongoing that I thought was really interesting. So I wanted to bring light to it, and hopefully we'll get some research out of it in the future. So there's this company called BioBot Analytics. It's actually a startup that's out of MIT, Mass Gen, and Brigham and Women's Hospital. And they're looking at testing poop from 329 sewer systems to try to estimate the amount of community spread and asymptomatic infection, which is really interesting to me. So, we know that the virus is in feces, so why not check the sewer systems for epidemiologic data, which is exactly what they're doing. So their goals are basically to trend the analysis and sort of determine when we can safely open up, or we're pretty much already doing that, and keep open, but basically to monitor the communities and sort of use it as like an early warning sign to sort of detect the reemergence of COVID-19. And not only that, you can test at scale. I mean, you think we talk about pooled testing a lot, but this is like the ultimate pooling of testing. So this is really, I think, just a different way to think about epidemiology and research. And I really applaud these guys for going after this. This is really interesting.
Yeah, and I want to take a step back. I mentioned earlier about policymakers and trying to open back up, even though cases are going up. I'm not necessarily saying that's wrong. I just think it's interesting. I mean, if we find that in these analyses, like this group is doing, that a massive number of people are getting this, but it's much less virulent because initially we were just catching the people who are sick, that's fine. I don't think we have that data yet. A lot of people are talking about that, but it's something to keep in mind. So these surveillance studies, whether it's this or asymptomatic testing, they're going to give us great information, but we need to look at it objectively and not just from the standpoint of we want to do certain things, so we're going to do certain things. I want to keep being data-driven in everything we talk about. Which brings me to my favorite study to talk about. Mike, I'm going to let you talk about it because it's one that you were wrong on something, right?
Thanks for reminding me. I was going to lead with that, but it sounds so much better when you lead with that and talk about me being wrong.
I just like saying
admitting it. Yeah, I'm sure. Yeah. So I'm going to talk about a few things, but yes, I'm going to talk about that study. I want to focus in on cholesterol and ApoE and COVID-19 for a minute, because we're getting some new research to suggest that there's truly something there. Now, I think maybe it was the webinar where the concept of statins actually being beneficial for COVID-19 was suggested. And at the time, there definitely was no data to really validate that and suggest that it's actually true. So we kind of poo-pooed it, and now it's time to eat a little crow because now there's some data. So I'm going to get to that, but first I'm going to start talking about ApoE. Now, Matt, you should remember ApoE pretty well. We talk about it a lot on the precision medicine side of the podcast because it's basically associated with dementia and cardiovascular disease risk. ApoE is a cholesterol carrier protein. It binds to the LDL receptor on cells and basically allows the cells to take up the cholesterol. So it's obviously important for cholesterol transfer within tissues in and out of the bloodstream, right? And it's been linked to dementia and cardiovascular disease. I mean, that's a huge thing that we talk about, is that people with two ApoE4 alleles or two ApoE4 genes basically end up with an increased risk of dementia by something like 15 times and a 50% increase in cardiovascular disease. So it's nothing to shake a stick at. But something that we don't talk a lot about is how tightly ApoE4 is related to the inflammatory response. And scientists have recently suggested that ApoE4 could be correlated with COVID-19, probably because of that inflammatory response. Early studies suggested that there was a relationship between HIV infection and ApoE4, where basically people who had ApoE4 had increased cell entry of the virus and faster disease progression of HIV. So we've known that there's been something there in the past, whether it's related to inflammation or viral replication or something, but we haven't been able to really put that together. It turns out ApoE is expressed in the lung tissue, and it's actually related to interleukin release from macrophages. Macrophages are inflammatory in cells, and interleukin is something that they use to communicate inflammation and sort of activating this concept of the inflammasome, which you may have heard people talk about in terms of the severity of COVID progression. So in addition to economic inequality, this is actually suggested as a potential reason why African Americans have worse disease progression, because the ApoE4 is twice as common in African Americans as it is in European descent. There was a study in UK that was just recently released, and this was looking at ApoE4 genotype patients. And they suggested that the ApoE4 predicts severity of COVID-19 in their community cohort. So what they did is they looked at a genetic biobank in UK and pulled out patients who were ApoE3 or ApoE4 or ApoE44, and they matched them against ApoE33 controls. So basically the E4 is the bad one, the E3 is the good one. You can be two E3s, you can be one E3 and one E4, or you can be two E4s. They looked at a total of almost 400,000 people. They found that of those people, about 622 tested positive for COVID-19. 37 of those people were E4, 184 were E3, and 401 were E3. And what they found is in a linear progression, basically there was a higher rate of infectivity in people who were E4, slightly less in E3, and then the least in E3, suggesting an increased rate of infection based on the number of E4 alleles. So that comes out to an odds ratio of 1.14 for E3, and 2.31 for E4, which is greater than a 2 times risk if you've got two E4 alleles for ApoE.
Well, the first thing you would think about when you see this, or one of the questions you should be asking yourself, is this just a correlation? Like E4,
Exactly.
E4 is probably going to be sicker than a 3. So is it just the other comorbidities that cause this? Did they control for that?
They did, exactly. So ApoE4 is associated with cardiovascular disease, as mentioned. It's associated with dementia. It's associated with hypertension. All of those things are independent risk factors for COVID-19, right? So they controlled for that. They basically, through their linear regression model, they removed out those patients, compared them against matched controls, and they came out with almost the exact same odds ratio, independent of dementia, hypertension, cardiovascular disease. So it does look like there is something there. What is there? They don't really go into. So why does ApoE4 lead to a greater risk of COVID-19 infection and progression of disease? That study didn't go into it, but another study, the one that you're talking about where I have to eat crow, does actually go into it. So this is called the role of high cholesterol in age-related COVID-19 lethality. So the theory behind this paper is that cholesterol is at play, and it's needed for SARS virus to enter the cell, and it's also needed for the ACE2 enzyme to come up to the cell membrane and expose itself, so the SARS-2 virus can actually attach to it. And basically, this is on something called a lipid raft, which is just an awesome name. So this lipid raft kind of creates this communication between the SARS-CoV-2 virus and the ACE2 enzyme, and allows for the interaction to happen, so that basically the ACE2 enzyme that's now has the SARS-CoV-2 virus attached to it can be digested into the cell and then go on to replicate. So this is interesting because studies have actually shown that children and patients on ACE inhibitors have higher ACE2 expression, but less infection and less severe disease. So cholesterol's role could actually explain why that's the case. If these people are on ACE2 inhibitors or are children and have higher ACE2 expression, but yet have less disease progression, it could be cholesterol that's actually playing the role that allows to increase the risk of infection in older patients. So this group used basically super resolution imaging to look at actual tissue cells that are exposed to high and low levels of cholesterol and the SARS-CoV-2 virus. And they used ApoE, which is now coming back into play, as a way for these for cholesterol to sort of communicate or to get into these cells. And they showed that higher cholesterol brings both LDL receptors and ACE2 enzyme to the cell surface, which is basically increasing viral points of entry. And they showed that it does this by 2x. So you get 2 times more virus in the cells if they are sitting in a culture of ApoE and cholesterol, rather than not in a culture of ApoE and cholesterol. Now, the one thing they do a good job of talking about is that tissue cholesterol is actually important, not serum cholesterol. So you can't immediately go and apply this to LDL cholesterol levels or total cholesterol levels. Now, the reason for that is because what's in your serum is not necessarily what's in your tissue, right? There's 4 things that get cholesterol from the serum inside the blood vessels into the tissues. Those 4 things are: 1, a high gradient. So if you've got a lot of cholesterol in the serum, more of it's going to sort of get into the tissue. Inflammation. When you have inflammation, it kind of opens up the vessel walls. It makes them more permeable so that the cholesterol can sneak through the serum into the tissue. 3, endothelial dysfunction. So if the lining of the arteries don't work as well, then it's easier for the cholesterol to get through the lining and get between the cells. And actually, that can be increased with high blood pressure and insulin resistance, 2 things that we know are independent risk factors for COVID-19. And then time. The more time you spend with higher cholesterol levels, the more of it gets into your tissue. And this is potentially where age is starting to play a role, right? So if you are older, you're more likely been exposed to high cholesterol levels longer. You've got higher levels of cholesterol in your tissues. And for that reason, they're suggesting that COVID-19 might be more virulent and causing more severe disease in elderly patients. This is really interesting stuff. And this is potentially the thing that could be bringing it all together to make a little bit of sense, at least physiologically, as to why COVID-19 is being so picky about who it infects asymptomatically and who it affects to the point that obviously they get morbidity and mortality from the disease process. And cholesterol could be at the rub of it, which is super interesting for me.
I am very excited. I've already added this to my Evernote file of times Mike was wrong, and I've got already set up an auto reminder because I randomly text him about different times when he was wrong. So this is good to have some new information going into there. Let's get really granular. Like, how does this, not to get too personal, but you have an ApoE4 and your LDL is higher. Like, are you worried about yourself? I mean, you're very young and you're healthy. Like, how do you translate this for yourself? Like, did you get any more worried reading about this? Not to put you on the spot.
A little bit. I mean, I'm not as worried because that stuff is managed for me. So, just having high cholesterol is not enough necessarily to suggest that you've got a severe increase in disease risk, because you have to have more than just high cholesterol in your serum. It has to be in your tissues. And, I've, at least after about the age of 20, I've been a pretty healthy guy, fairly low levels, I think, of inflammation. I've, worked really hard, as you know well, over the last, 10 years or so to get my cholesterol down. So, do I have an increased risk compared to somebody like you who has pristine cholesterol and no inflammation and, no evidence of arterial sclerosis or cholesterol in your tissues? Probably. Yeah, I've probably got an increased risk. But what else am I going to do about it? I've already maximized my cholesterol levels. I've already decreased inflammation. I've, continued to work on insulin resistance and endothelial dysfunction. The thing that's so exciting to me about this, Matt, is that this is at the heart of what we do with Wild Health. And it's proving to be, maybe one of the most important predictors of the severity of COVID-19, which is just super cool for us, I think, in the sense that hopefully all of our patients, because these are the things that we focus on so closely, are at lower risk because of it. So sure, while I might have a slightly higher risk, I have optimized that risk. I know to the best of my ability. So I could at least got that going for me, I guess. It makes me feel better.
Yeah, you bring up a great point. I mean, you've done what you can maximally. So at this point, the next step for you, the only other thing to do would be to worry intensely, which would decrease your immune response and make things worse. So yeah, I mean, I think that's a great approach. Do everything you can with as much data as you can, and then I'm glad you're not worried.
I think that what the take home for our listeners should be, this is not a death sentence. Cholesterol is something that you can control. Inflammation is something that you can control. High blood pressure and insulin resistance are something that you control. And all of these things are, based on this study, the things that could be leading to increased risk of COVID-19. So, if nothing else, I like that a lot better. I like those odds a lot better than, any of the other predictors that have to do with, genetics that you can't control, towards the development of COVID-19 and the progression of disease. So yeah, for sure. It's good information, but risk factor stuff, like always, is probably so much more, lifestyle, I should say. Factors are probably so much more important than these other genetic factors. 100%. Matt, before we leave today, I wanted to take a minute and talk about racial equality. So the events over the last week have really been horrible and really sickening. And I know we, like the rest of society, really expect action, and for all of us to speak out about racial injustice. Personally, I think we've been a little slow to speak up, and that's because we wanted to find a way to do more than just talk about it. Of course, Black Lives Matter. Of course, racial inequalities that are rooted deep in our society need to be righted and they need to be changed. But at Wild Health, we want to do more than just speak up. We, like I think the rest of the world should do, we want to take action. So what can we do? Well, we're physicians and we're leaders in healthcare. So in my mind, it makes the most sense for us to focus on righting the wrongs of racial inequality in medicine itself.
Yeah, and it's a great point you make about taking action, not just saying something. Last week I was talking to a friend of mine who happened to be in a really interesting situation. He had been up all night the night before because he had been at protests. He is a black man. He's a police officer, and he's a great person. So instead of talking, I just mainly listened, and he was very open about telling me what it was like to be pulled over for nothing growing up, what it was like to get thrown to the ground in a park by a police officer for nothing. And now he told me what it's like to have fellow black men, many of whom he knows their families well, call him a traitor, and spit at him at the protests. It was really heartbreaking to listen to him, and it was really frustrating to not be able to do or say anything that really helped. I just said, "Hey, I'm sorry, that sounds horrific. How can I help?" He didn't really, there really wasn't anything I could do, though, at that time. He didn't really have any action items for me, and honestly, I think he just wanted to sleep. He was tired. So we've been thinking about what we can do. And last night I was watching the news, and I saw this enormous mass of people gathering in close proximity. Not a whole lot of social distancing. There was a lot of yelling, which can spread the virus. I saw a couple episodes of tear gassing, which can spread the virus even worse. And there were a lot of people without masks, and it really concerned me. And then today, when I saw the news, like I just mentioned at the very beginning, about cases rising in Texas and doubling in Arizona and on the rise in Kentucky, where I am, and I think most of that is probably from the reopening, but I do worry about the effects of what all is going on right now. But people have to be able to peacefully protest, and they have a right to demand change. So what can we do? Well, we're not going to lecture, or we're not going to just pay lip service, but one thing we can do is test. So we decided that our response and action, not just a statement, is going to be to do free testing for those that have been at protests and want it, if they're worried about their exposure. Right now, we only have the ability to do testing in certain areas, but we're organizing now to do that. Mike and I are in Lexington, Kentucky, and Bend, Oregon. So we're still working out the exact details. I'm waiting on a couple pieces of information about where and how exactly, but it's going to be completely free testing that we'll pay for. We would love to do testing in other places as well, but there's quite a bit of logistics to work it out. So for details of where and when, if you're interested in getting this testing done for yourself, go to wildhealth.com. Some people may not have great access to care. So in Lexington, for example, we're going to do it downtown where the protests have happened and are continuing to happen. There's a business called Awesome Inc. on Main Street, and we're probably going to be doing it there. Again, I'm waiting for, there's a final piece of information I'm supposed to get, and we're recording this now. So the time and where we're going to be setting up, we'll announce where, we'll put it on our social media also. And even this action, it really feels anemic to me in short term. But I do think that this level of minor action, it at least feels better to us than simply pushing out a statement or a hashtag on social media. And really it's hard to do anything that doesn't feel inadequate or like a PR stunt, and to actually be something that helps. So hopefully this is just that. Hopefully it's something that will help. And it's small, but we would encourage other people who aren't in a minority like us to think hard about what you can do as well, not just say. Even if it's just listening or something small like this that we're doing, what I would say to you is just do it. And thanks for listening to us.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.